We are ruthlessly decoding cerebrovascular and epilepsy protocols today to build your clinical pattern recognition for the USMLE Step 2 CK. This explainer is all about stroke protocols and epilepsy algorithms, so let's get right into it.
Here's our clinical pathway index for this session. We'll be hitting acute ischemic stroke reperfusion windows, clinical seizure classification and pediatric spectrums, status epilepticus pharmacological emergencies, and finally, accelerated pattern recognition and neurological traps.
Starting with Module 1, Acute Ischemic Stroke Protocols and Reperfusion Windows, specifically focusing on hyperacute timelines and contraindications.
Now, in neurology, time is literally brain. Your very first move is always to map the patient's deficits to the anterior, middle, or posterior cerebral artery territories to establish the ischemic anatomy. For example, if a patient comes in with arm weakness and language deficits, you've got to instantly recognize that middle cerebral artery involvement. Nailing the localization right out of the gate sets up your entire management pathway.
But before you do anything else, the absolute, non-negotiable first step in any stroke code is a non-contrast head CT. Why? To definitively rule out an intracranial hemorrhage before you even think about intervention. Sure, a negative CT during the acute phase doesn't totally rule out an ischemic stroke, but it's an absolute requirement to safely move forward with any reperfusion therapies.
You need to memorize these exact temporal limits. Hour 0 is the last known well, or LKW. Intravenous alteplase, or TPA, is strictly indicated within 3 to 4.5 hours of symptom onset. Meanwhile, mechanical thrombectomy for large vessel occlusions of the anterior circulation has a wider window, extending from 6 to 24 hours. And here's a crucial rule for secondary prevention. You only initiate high-intensity statins and antiplatelets strictly after hemorrhagic transformation is completely ruled out.
Now, whatever you do not administer TPA if the patient hits any of the absolute contraindications. We're talking active internal bleeding, a history of prior intracranial hemorrhage, recent major surgery, or a stroke within the last 3 months. And pay very close attention to this one. Severe, uncontrolled blood pressure exceeding 185 over 110 millimeters of mercury is an absolute no-go for TPA.
Let's put this into practice with a classic board trap, the wake-up stroke. Imagine a patient wakes up at 7 a.m. with severe left-sided hemiparesis after going to bed at 11 a.m. the night prior. A non-contrast CT is negative for hemorrhage. So, what is the next best step in management?
Well, because the patient's last known well was 11 p.m., right before they went to sleep, they're 8 hours out. The strict 4.5-hour TPA window is totally violated, making TPA completely incorrect here. Instead, you're forced to evaluate for mechanical thrombectomy by ordering perfusion imaging, like a CTA or MRA, since the patient is safely within that 6 to 24-hour window. And a quick reminder, never ever delay acute imaging or interventions just to wait for routine lab results. Plus, hold off on immediate antiplatelets until reperfusion decisions are finalized.
Moving on to Module 2, Clinical Seizure Classification and Pediatric Spectrums. We're going to focus on differentiating onset and awareness.
To navigate these presentations, this clean differentiation matrix is going to be your best friend. We categorize seizures purely by their hemispheric onset and whether the patient's awareness is retained or impaired. Focal seizures start in a single cerebral hemisphere and are subclassified strictly into with versus without impaired awareness. Generalized seizures, on the other hand, involve bilateral hemispheres right from the start, and they feature an immediate loss of consciousness, along with symmetric motor activation like what you see in tonic-clonic seizures.
Let's zoom in on a highly tested generalized seizure, childhood absence seizures. These present as sudden, brief staring spells occurring mostly in kids. And here is the absolute key. Do not confuse these with focal impaired awareness seizures. Absence seizures completely 100% lack a postictal state.
Clinically, you'll see a sudden stop in motion, maybe some lip smacking or eyelid fluttering, and these can actually be provoked by hyperventilation. You absolutely must commit the EEG hallmark to memory. Generalized 3 Hz spike and wave discharges. For first-line therapy, you're going with ethosuximide. If you need a second-line option, valproic acid is your go-to.
Let's try another high-yield question. Picture a 7-year-old boy who frequently stares blankly for 10 seconds and stops talking, then immediately resumes his activity without any confusion whatsoever. What is the underlying diagnostic hallmark of this condition?
This vignette is practically begging you to differentiate an absence seizure from a focal impaired awareness seizure, also known as a complex partial seizure.
The silver bullet here? The post-event recovery. The absolute lack of a postictal state immediately rules out a complex partial seizure. This confirms we're dealing with an absence seizure, meaning you'll see that 3 Hz spike and wave pattern on the EEG.
Let's jump into Module 3, Status Epilepticus Pharmacological Emergencies, where we'll cover the step-by-step emergent rescue sequence.
Status epilepticus is a massive medical emergency. It's rigidly defined as continuous seizure activity lasting 5 minutes or more, or multiple discrete seizures without an intermediate recovery of consciousness. The second that 5-minute threshold is crossed, you have to immediately initiate a mandatory pharmacological countdown.
This timeline strictly dictates your intervention. The first 5 minutes are the abortive phase. Minutes 5 to 20 make up the stabilizing phase, and anything going beyond 20 minutes, that's the refractory phase.
You have to execute this sequence perfectly. Step 1. The abortive phase. Give immediate IV lorazepam or IM midazolam. Step 2. The stabilizing phase. Non-sedating, long-acting anticonvulsants are mandatory right after that initial benzodiazepine. That means pushing IV fosphenytoin, valproate, or levetiracetam. If the seizures still won't quit and you hit Step 3, the refractory phase, you have to escalate to continuous anesthetics like propofol, phenobarbital, or midazolam. And listen closely, reaching this stage strictly mandates endotracheal intubation.
Time for a critical management trap. A patient arrives actively seizing. You administer 4 milligrams of IV lorazepam. 5 minutes later, the patient is still exhibiting generalized tonic-clonic activity. So what do you do when that first-line abortive therapy totally fails?
Whenever you do not repeatedly stack ineffective abortive sequences. Giving more benzodiazepines without initiating a stabilizing agent is a fatal error on the boards. You must immediately escalate to Step 2 and push a stabilizing agent like IV fosphenytoin or levetiracetam.
Now for our final section, Module 4, Accelerated Pattern Recognition and Neurological Traps. We're going to catalog the major cognitive pitfalls you need to actively avoid.
To score in the elite percentiles, you have to anticipate the test writer's traps. A classic pitfall is delaying reperfusion therapy. Let me be clear. Unless the patient is on systemic anticoagulation, never delay TPA to wait for routine laboratory values or a stroke specialist consult. Time is brain. Also, never give TPA to a patient whose last known normal time is ambiguous. You have to respect that strict 4.5-hour cutoff.
Here's another massive trap. Never initiate third-line continuous anesthetic options for refractory status epilepticus without strictly securing the airway first. Pushing propofol or high-dose phenobarbital will cause catastrophic respiratory depression. Failing to intubate before pushing those drugs is an automatic failure of the entire algorithm.
So, let's bring it all together. Can you instantly recognize the 4.5-hour TPA cutoff, that classic 3 Hz EEG pattern for absent seizures, and the exact moment you need to push fosphenytoin in status epilepticus? Master these rigid timelines, matrix differentiators, and red box traps, and you'll turn these complex neurological emergencies into instant points on test day. The next time the clock starts ticking on a hyperacute stroke, will you hesitate or will you execute the protocol flawlessly?